Good afternoon, everyone. Thank you for joining me today. My name is Hafsa Ishtiaq, and I'm going to be presenting on some renal pathologies, namely hydronephrosis, page kidney, and renal infarcts. The outline of my presentation today is I'm going to give a brief objective of my presentation, an introduction to the topic, talk about what the normal imaging looks like for the kidneys, and then dive into the pathologies, basically hydronephrosis, page kidney, renal infarct, and then provide a very brief conclusion, which is a summary of my findings. The objective of my presentation today is to identify the main radiological modalities used to diagnose the three renal pathologies. We will see quite a bit of ultrasound and computerized tomography. I'm going to identify the main radiological features of each renal pathology, and keeping in mind the time limit of the presentation, I'm going to provide at least one differential diagnosis using imaging. So an introduction to the kidneys. The kidneys are very essential organs that are important to maintain our pH and electrolyte balance, and they help filter our blood of waste products. These are retroperitoneal organs that are located in the posterior abdominal wall, and we can find one located on either side of the vertebral column within the perirenal space. They usually extend from the vertebrae T12 to L3, and they can be found, their lateral border can be found parallel to the border of the psoas muscle. In terms of their size, well, literature reports that they can differ between males and females. However, generally they are between 9 to 14 centimeters. We know that the left kidney, the kidneys are actually asymmetrical, and that the left kidney is slightly longer and narrower in adults as compared to the right kidney. The right kidney also tends to sit a bit lower because of the liver that is on top. In terms of its structure, they are recognized for being bean-shaped. They have a superior and inferior pole. They have an anterior and posterior surface, and they have a lateral and medial border. Just as a reminder of its anatomical structure, we have the kidneys here that have a cortex. They have a renal parenchyma. We have these medullary pyramids. When blood gets filtered and the urine is formed, that filtrate, it drains into these minor calyces, which then combine to form these major calyces. These major calyces form these pelvis. From here, that filtrate is then passed on to the ureter. We can find in the ileum, or this medial aspect, different structures such as arteries and veins. So basically, the blood vessels, not illustrated here, are also the lymphatics, some fat, some perirenal fat, as well as nerves. In between each of the medullary pyramids, or separating the minor calyces, we have these renal columns. Okay, so in terms of what is considered normal then, when we look at the kidneys. So when we order a radiograph, a clean film radiograph, we usually want it to focus on the lower abdomen. And this is specifically for renal function. We can have the kidney, ureter, and bladder radiograph that's asked. On the left, we have a plain film abdominal radiograph taken in a supine view. The reason for putting this image here is, even though we can't very well visualize the kidney, it still gives us a sense of where they are located anatomically in relation to other parts of the body. Here they are labeled as kidney. This would be the right kidney, and on this side we would have the left kidney. Here you can see that they are highlighted in yellow. Because they are retroperitoneal, you will often see sort of the bowel loops that are on top. So if we do require a radiograph of the kidneys, it is often helpful, instead of just having a plain film radiograph, to have an intravenous pyelography, which is basically when a water-soluble, non-ionic medium of contrast is injected into a patient. In doing so, we are able to visualize different aspects of the kidneys. Usually within less than 2 minutes of having injected this non-ionic or water-soluble contrast material, We can visualize the calyces. Here we can observe the minor calyces, the major calyces, the renal pelvis, and the ureters as the draining is occurring. When we talk about ultrasound in the kidneys, there are two projections. This is a transverse plane of an axial section of the mid portion of the right kidney. There are certain features that we need to keep in mind. Here we have the actual ultrasound image, and here is an illustration that helps clarify what we're actually looking at. As you can observe, if we compare the two, here we have this structure being the actual kidney, and this portion here representing the ileum. Before dissecting each part, it's important to mention that when we take an ultrasound, what we see is basically a heterogeneous image. Basically, there's mixed echo patterns versus where we have a different appearance in the cortex versus the sinus. The cortex being this aspect over here, the surrounding part, is usually a mid-gray tone, and it's usually homogeneous, so not a lot of different coloring aspects. It has a smooth contour. The sinus, which is mostly this inner part here, you can see that it's bright. It's more hyperechoic, it has irregular borders, and it can be interrupted by anechoic urine-filled medullary pyramids and vessels. Anechoic meaning that it's just basically black, that the sound waves go right through it. So as we can identify, this black part here are the medullary pyramids. We have the renal sinus here, which is whiter, and that is due to the structures that I mentioned earlier, the perirenal fat, the vessels, the drainage, the lymphatics, and the blood vessels, yeah. And then, so this just helps us observe the ultrasound imaging a bit clearer, where we have the cortex, we have the pyramids here, we have the medullary area here, usually fat, which helps us observe it as being more white, and then the renal pelvis highlighted here. This is a transverse projection or a transverse plane of the kidneys. Here we can observe the similar mixed heterogeneous pattern where we have the pyramids observable here, the cortex around this area. Here we have the medullary fat that's highlighted, and then the calyces and the renal pelvis here, or also you can observe it in color on the side. This is a longitudinal plane of the left kidney, an ultrasound. Similar heterogeneous patterns are observed, and we are able to, as we compare it with this illustration, we are able to identify the medullary pyramids here, the renal sinus that we observe as being more hyperechoic or white, and then the cortex, the renal cortex, which is smooth in contour and relatively homogeneous in color. So with then we move on to the modality of the computerized tomography. This was important for me to learn because it helped provide me a clear understanding of when we order a CT scan of the kidneys and when we ask for it to be with a contrast, that we need to be mindful that there are different phases, usually 3 to 4, depending on which author you follow, that helps us visualize the kidneys appropriately. The first phase is known as the cortical medullary phase. Upon injecting an intravenous contrast material, it takes about 40 to 80 seconds after the injection to visualize this. It shows usually a bright enhancement of the renal cortex, which in comparison to the renal medulla, it remains, the renal medulla in comparison remains very low in attenuation. That is to say, something appears more white versus something appearing more gray or blackish. Then we have the nephrogenic phase, which occurs about 100 seconds after initiating the contrast injection. There is usually a uniform enhancement of the renal cortex and medulla. And then we have the excretory phase, which some authors divide into early excretory and late excretory phase. The early excretory phase is about 150 seconds after the contrast injection. It's basically when you start to have the excretion of your contrast material, which is mixed in with your filtrate, into the renal collecting systems. And the imaging at this point can remain somewhat homogeneous and bright between the renal cortex as well as the sinus area. And then you have the late expiratory phase, where your renal parenchyma attenuation is much less intense than it was shown in either phase 2 or 3. So this is just purely an image placed to demonstrate the different levels of attenuation that happen in each of the phases, A, B, C, D, corresponding to each of the different phases. The first one being cortical medullary, the second one being nephrogenic, the third the early expiratory phase, and the fourth being the late expiratory phase. So in the first image, image A, you can see that there is definitely an enhancement of the renal cortex in comparison to the renal medulla, which maintains a low attenuation. Here you can see in the image B that there is a somewhat uniform contrast now, the filtrate and the injection. The contrast is now entering into the medullary area. This is the early expiratory phase. Even though it may seem it may seem homogeneous, you can observe here, closer to the helium aspect, that it is actually a bit more attenuated, it's brighter. And finally, in D, you have the late expiratory phase of the contrast injection, where the renal parenchyma attenuation is much less intense as compared to the previous images. So in your computerized tomography, you can also have different projections. This is a CT abdominal scan with contrast. This here is an axial projection. This one is a sagittal, and this one is a coronal. And as you can observe, given the description that I gave earlier, these are your cortical medullary phases. In magnetic resonance imaging, we can observe the kidneys. Usually this provides the greatest amount of detail in terms of resolution and being able to sort of very well distinguish the different images. When we have a T2 weighted magnetic resonance imaging, usually what that means is that any structure that contains liquid like water is going to definitely appear with a very high attenuation. So here we see a normal kidney, but on the right, a hydronephrosis, and this image will be repeated later on in my presentation. We can see that there is an abnormal collection of water. There is a very high level of attenuation that is being observed in the kidney. So this whiteness that we see, this high level of attenuation, this brightness, indicates a component that contains water. So now we dive into our actual pathologies. So hydronephrosis refers to a dilation of the kidneys, where we have a dilation of the pelvis and the collecting systems. Its main cause is usually obstruction. There can be obstruction in the ureters, in the outlets. What that causes is that there is a hindrance to the free flow of urine. This can in turn cause a retrograde pressure, dilation. It can cause parenchymal damage, and it can generally lead to an impairment of function. And if not treated or addressed in an opportune fashion, it can cause a loss of renal tissue that can be irreversible. Hydronephrosis, you will often see the kidneys being large with cortical thinning, and as well as some signs, some radiological signs. So there was an article that I found that's it's classical signs in neuroradiology. And these are the radiological features of an axial CT with contrast when you are faced with hydronephrosis. The authors basically identified 3 main signs for identifying hydronephrosis. The first one is the hydronephrotic rim. This is usually observed in chronic hydronephrosis. And when you administer the enhancement, you can often see a renal parenchyma that is atrophic, and it's surrounded by dilated calyces and renal pelvis. So here we can see that this aspect here, if we compare it to the normal, we can see it is much thinner, basically referring to the atrophy, and that the renal calyces and pelvis is a lot more dilated. Here we can see with the lower attenuated image of how much blackness, so to speak, we are able to observe as compared to this one over here. So this type of rim has been observed in all forms of contrast enhanced imaging of the obstructed kidney. They mention a crescent sign. So the crescent sign is here where the arrows are pointing, and it's the appearance of concentrated contrast material in collecting tubules parallel to the margin of the dilated calyx. This change in tubule orientation from vertical to near horizontal at the margin of the calyx being here is related to prolonged but often incomplete obstruction that produces a gradual dilation of the collecting system. It's important to be able to identify this crescent sign because it can be an indication that renal function is recoverable. And then they have a balloon on a string sign, which is where you have a high and eccentric exit point, eccentric meaning that it's no longer medially, but rather to the side, more lateral, of the ureter from a dilated renal pelvis. And it's a typical finding of the uteropelvic junction obstruction. Uteropelvic referring to basically where the pelvis of the kidneys and the ureters meet. So here you see a normal kidney with a normal uteropelvic junction. You see that this is basically in the middle, it's not eccentric, and that there's no sort of dilation that it's occurring of the renal pelvis. In turn here, you can see why it's called a balloon on a string, because your ureter is off to a side, it's eccentric, it's quite thin, and then here you have this larger circular or globulous mass, which is referring to the hydronephrosis. So when we do a CT scan, you can grade the hydronephrosis based on the amount of dilation that is visible. So in this case, we have grade 1, grade 2, grade 3, and grade 4. I should mention that there are different authors who have suggested different grading patterns. So this is by no means the only one that exists, but because of the imaging, I have placed it here. In grade 1, we see pelvic dilation only. So we see that this area appears more gray, and usually this is about 5 to 7 millimeters in terms of its dilation. Here in grade 2, we have mild calyx dilation, calyxasis, and here we can see the major calyces and the renal pelvis that appear larger and wider in size. Grade 3, we have severe calyx dilation, again calyxasis, where this measurement is usually more than 10 millimeters. And then in grade 4, we have renal parenchymal atrophy with that cortical rim sign. We can observe it very clearly here. We can see that the parenchyma is no longer visible as it should be, and that there is quite a severe dilation of the calyx and renal pelvis. Okay, so here in this imaging, just more images of a coronal view of an intravenous urogram. Where we can observe here in this area that is more radiolucent, we can observe the actual kidney stones, and here we can observe that the kidney, there is no drainage of the actual contrast material. And here a coronal CT with contrast of the kidney, ureter, and bladder, where we can observe very clearly as compared to the normal kidney, the grade 4 hydronephrosis. Here, another image of a coronal CT without contrast, and not only are we able to observe the dilation, but we are here in this more attenuated image, we are able to see the actual obstruction, which is a calculus that they were able to identify. So when we talk about the ultrasound, the radiological features are that a normal kidney, the center of the kidney should be echogenic because of the presence of sinus fat, and the calyces are not visible unless they're really dilated. Those are usually hypogenic, but in hydronephrosis, we observe the kidneys as branching, interconnected areas of decreased echogenicity that show evidence of fluid. And usually when we do have a hydronephrosis, usually the technician that is performing the ultrasound tries to visualize the ureter in case of in case they can identify the obstruction. So here it is a similar pattern to what was mentioned earlier in terms of the dilation. We go from having a normal kidney to one that is severely dilated, and the pattern holds the same in terms of the amount of dilation. So here we see the renal pelvis is is starting to widen. We can see that with this increased level of hypogenicity. Hypoechogenicity appears more black. That's grade 1. In grade 2, we can see how the major calluses are starting to be affected. In grade 3, now we have involvement of the minor calluses. And in grade 4, we can see now that they are quite wide, and also that the cortex appears visibly thinner. In all of these, the cortex maintains some level of thickness, but here there is quite a bit of atrophy that is occurring. Just more images in terms of ultrasound. We have a longitudinal image or projection of the right kidney. It appears normal. We are able to visualize the ileum, the wider aspect of it. Here, an ultrasound of a longitudinal image of the right kidney, grade 3 hydronephrosis with a dilated renal pelvis, and in grade 4, where the renal parenchyma is quite compromised, and there is a very large dilation of the renal pelvis, and this indicates a grade 4 hydronephrosis. Another image, ultrasound longitudinal view. On the left, we have the hydronephrosis of the left kidney with the dilated renal pelvis and major and minor calluses. And here we are able to observe on the right some dilated ureters underneath the lower pole of the kidney. I thought this was interesting because it's one of the few images I could find with the dilated ureters. Okay, in an MRI, it's what I was mentioning earlier in terms of when you have a T2 weighted MRI, you are able to observe water as a bright signal. And so any body part with a high concentration of water will appear more bright. Here we can see a dilation of the kidney parenchyma, the renal pelvis, the major and minor calluses. So an MRI can be useful as well, another tool. This is a coronal projection of a T2 MRI that's demonstrating bilateral hydronephrosis. So in terms of the differential diagnosis, we can have renal cysts, we can have an extra renal pelvis, and we can also have pseudohydronephrosis. Here in this image on the left, we are comparing what hydronephrosis looks like with an obstruction due to a calculus versus a simple renal cyst on the right. Upon seeing this, you would think you are observing a dilation of the renal pelvis just because it's so similar to what you're observing on the left. But as you can see, there is a difference in terms of how well the contour is, that it appears to be a little bit more contained. You are able to observe a difference in attenuation between the parenchyma as well as the cortex. And generally, this would indicate that there is some level of fluid here. There is no other part of the kidney that appears to be dilated. So this sort of dilation doesn't appear to be uniform. So this can help us in our differential diagnosis when we look for certain signs to differentiate it between an actual hydronephrosis and a renal cyst. And one of the main features that you can use aside from this CT of the abdomen that doesn't have a contrast is also an intravenous pyelogram, because an intravenous pyelogram would then show that there is a true obstruction and that there is fluid being accumulated in your hydronephrosis. Okay, and just, here we just see in terms of the ultrasound, we can see that in a cyst, the cyst originates from the adjacent parenchyma and protrudes into the renal sinus. You can see that it has this sort of interruption of the parenchyma. It's not one amorphous blob of liquid as you would see it here. So you can see that it's sort of separated. And so that can also help us in our differential diagnoses. Okay, now we move on to page kidney. So page kidney or page phenomenon refers to the systemic hypertension secondary to extrinsic compression of the kidney by a subcapsular collection such as a hematoma, seroma, or urinoma. It is most often diagnosed based upon ultrasound, which is usually the quick, cheap, and easy modality. That's sort of the advantage. And it can also be diagnosed using computed tomography, which can provide better imaging and can help us see sort of smaller collections. The main radiological features are that you're going to have a collection surrounding the kidney of a different density, so in terms of a different echogenicity. It's subcapsular in location, and the adjacent renal parenchyma is deformed more often than not. It is compressed. So here in ultrasound, we can see this retroperineal ultrasound longitudinal projection of the left and right kidneys. If we compare the left and the right kidneys, we can see that there's a very clear difference in the actual color or the echogenicity. It represents the presence of different densities. The blackness here that we see is hypoechoic, and it represents the presence of fluid. Whereas here we are able to see that sort of heterogeneous imaging, that sort of heterogeneous color, which tells us that the structures are conserved. On the right, which is where the page kidney is located, we see the renal cortex, which its typical gray appearance, homogeneous appearance, has been compressed here. And this indicates to us that there is some sort of fluid-filled structured anechoic that is compressing the renal cortex. We are also able to see here this light white color here, this light gray or white even, that's a different density that indicates to us that this is the capsule. So the capsule of the kidney, and that this accumulation of liquid is within the capsule. So again, repeating what I said earlier, we have the subcapsular fluid collection in the right kidney. It's an echogenic fluid-filled capsule. It's anterior to the renal cortex, and it's causing a medial compression of the renal parenchyma. Okay. In an axial computed tomography without contrast of the abdomen, this is the projection that we are observing here. We can see in the left kidney, there's a subcapsular hematoma where the arrows are pointing. This is a more attenuated image or attenuated image mass that is displacing the kidney parenchyma anteriorly and medially. And if you compare it to the opposing kidney, you can see that this density or this attenuation does not exist. Again, it is conserved within the capsula of the kidney. In this axial computed tomography with contrast of the abdomen, which shows the mid-kidney, the renal parenchyma of the left kidney is compressed by a high attenuation subcapsular collection. The reason I like this is because you can really see how the kidney, it's being pushed medially and anteriorly by this collection. And this collection seems homogeneous in nature. So it's some sort of fluid that is causing this compression, and it's displacing it as compared to the healthy kidney on the opposing side. We can also see that the compression is causing it to not be so attenuated, meaning that likely the capillaries are being compressed as compared to here, where the contrasted material is able to flow freely. Again, a coronal computed tomography of a KUV projection with contrast showing that the lower pole of the kidney is compressed by a mass that is highly attenuated, and it's subcapsular in nature, as you can see. Again, it's causing the compression of this. And again, the attenuation here is lower than the one here, likely because of the compression of the vessels, of the blood vessels. So the differential diagnosis, you will differentiate the diagnosis. The differential diagnosis will be basically things that will cause renal hypertension. For example, juxtaglomerular cell tumors, renal artery stenosis. There can be malignant hypertension. You can also have a differential diagnosis with acute tubular necrosis and renal vein thrombosis. I highlighted juxtaglomerular cell tumor because that is the one that I was able to find here. When we observe this enhanced axial computed tomography, we see a tumor here, which is slightly less dense than the renal medulla. And the way we are able to differentiate it is in page kidney, the collection is subcapsular. It is causing an anterior and medial compression of the renal parenchyma. Here, on the other hand, however, this mass seems to be pointing away. It's almost like protruding away from the parenchyma. It's not necessarily causing such a strong or dramatic compression of it. It almost seems slightly exophytic in nature. because you see it sort of protruding outwards into the perirenal space. And here we can see the difference in what a page kidney would look like, where you have a clear compression versus a juxtaglomerular cell tumor, where you don't necessarily see the compression occurring so dramatically, and rather you see a different mass with a different density here, different attenuation. And lastly, we have renal infarct. Renal infarct is a pathology that can occur due to arterial occlusion leading to renal infarction. It may result from thrombosis, an embolus, or trauma. The embolism is said to be the most common etiological factor. Renal infarcts are most easily identified on post-contrast images. The renal parenchyma will appear diffusely infiltrated and hypoenhanced with preserved enhancement in a subcapsular rim owing to perfusion from capsular arteries. So the cortical rim sign is, you can also observe it here. So here we have an axial CT contrast of the abdomen. There is hypoattenuation of the posterior inferior part of the kidney with surrounding stranding. This is known as fat stranding here, this sort of line that we observe towards the outside of the kidney. There is preservation of the outer layer of the parenchyma, and there's the cortical rim sign here. It's sort of, you're creating this difference in densities, different attenuations. This one, obviously, it has a lower attenuation. This one is higher, which means this would be the infarcted portion, whereas this would be the healthy portion, where your CT was able to flow freely, where your contrast was able to flow freely, sorry. In a coronal view, computer tomography with contrast, in this KUV projection, you see the cortical rim sign here. You see this part is the infarcted portion. You see the fat stranding here clearly, and you see that this is sort of the healthier part, which wasn't affected. And then you can contrast this with the healthier kidney on the opposing side, where you see it's homogeneous. The contrast material is able to flow freely through this kidney, whereas here, you only see it in a portion of the kidney and not in this inferior aspect. In this projection, the axial CT with contrast, you see a wedge-shaped non-enhancing lesion in the right kidney with no perirenal inflammatory stranding. So that sort of fat stranding that we saw earlier, where you saw sort of that stringy aspect behind the kidneys, we don't see that there, but you are able to see the difference in attenuation, where one aspect seems more attenuated, this one here, and the other less attenuation. So that can also help us indicate renal infarction. So there was a radiological feature that I came across in the literature. It's called flip-flop renal enhancement. Flip-flop renal enhancement describes when an infarcted renal parenchyma alternates between hypoattenuation during the arterial phase, which is when the contrast is flowing through, and hyperattenuation on the delayed phase of a contrast enhanced CT, and that being when the contrast is actually passing from the arteries onwards. There may also be associated fat stranding and thickening of the surrounding perirenal fascia. So this is apparently the flip-flop phase. This is apparently the flip-flop phase. Basically, you are able to see an optimal enhancement of the structures. They're getting their blood supply directly from the arterial system. That's why you're able to see that one appears more white and the other one darker. And here in the delayed phase, which is also sometimes called the washout phase, there is a diminishing or almost a disappearance of the contrast, except for, of the contrast. And so therefore it appears more dense. It almost seems like they have the same density. So a differential diagnosis can be pyelonephritis, where there isn't an absent cortical rim sign. So here we can see that there is a rim sign here, which would be the infarcted kidney. But here in pyelonephritis, we don't observe that. You would almost think that this area here, which is more hypoattenuated, is an infarcted kidney, but it's actually, it's a differential diagnosis with pyelonephritis. So just something to keep on the lookout for. I believe I read, and I can't remember now, but I believe I read that usually when you want to make a differential diagnosis, definitely you have to use the clinical signs that are presented to you to have a much clearer understanding of the pathology at hand when it comes to differentiating pyelonephritis from a renal infarct. So just to conclude then, for each of the three pathologies that we saw, hydronephrosis, renal infarct, and page kidney, the two modalities that are really commonly used in hydronephrosis are an ultrasound and CT scan. The main feature is a dilation of the collecting portion of the kidney, which are the renal pelvis and the calyces that produce many signs and parenchymal atrophy in their varying degrees. We spoke about 1, 2, 3, and 4. And here we can observe the dilated kidneys, the dilated renal pelvis, and the cortical rim sign as being two obvious features. In the renal infarct, the modality that helps us diagnose it or visualize it the best is usually the computerized tomography. We have a cortical rim sign and flip-flop enhancement with fat stranding, which we can observe here. And in the page kidney, the main modalities that we can use are ultrasound and CT scan, and we observe a compressed parenchyma by a subcapsular collection of a different density. And hopefully seeing these three pathologies one next to the other, you are able to better visualize them and their differences. Thank you very much for your time and attention. Here's my bibliography.